Getso, good afternoon. We're going to start at 7 o'clock, but in the meantime, we'll play this showing shortly just for you to keep seeing something what ECTOPIC is all about. But the main show will start at 7 o'clock. Sure. Getso,
Hi, Doc.
how are you?
I'm good. How are you?
Didn't it mute you automatically when you came in?
No, I was muted. Kiki Feto unmute no when you're greeting me.
Oh, mute. But I said it must mute you automatically when you come in.
It was muted.
And I said I shouldn't allow you people to unmute yourself.
Oh, okay.
Security. Unmute themselves. Okay. I'm not going to allow you to unmute yourself.
Okay.
Sure. I'm starting now. But we'll start at 7.
Yeah, no, I was just joining in just to make sure I get a space. Can I mute myself?
Yeah, mute.
Mute. Oh, okay. Sure.
Let me check again. We will be starting the meeting at 12 at the exactly 19 hour. We just showing shortlist as we are waiting for people to trickle in. We may just be watching this ectopic pregnancy. We are left with only 4 minutes to start the meeting. We will start the meeting exactly at 19 hours. We're just waiting for people to trickle in. What you see here is laparoscopic management of ectopic pregnancy by laparoscopy. You can see the bleeding there, and adhesions be removed from the tube, and the affected tube is tied with an endoloop. Then it will be cut. That will be the end of the operation. There's a laparoscopic scissor there, cutting the ectopic pregnancy. Because it's been tied, there won't be any bleeding. In the next 3 minutes, we'll start the meeting. The tube is cut completely now. You can see the stump there has been tied with an envelope. The tube is put in the part of Douglas where there's blood, which is the most dependent area of the body. When the patient bleeds, blood goes to the most dependent area of the body. And to expose this ectopic, you suck the blood out and remain with a specimen of fallopian tube with ectopic pregnancy inside it. The ectopic pregnancy is put in the endopouch, which is the pouch that we collect the specimen with, so that you can be able to harvest the specimen and harvest it and take it out of the body. This specimen with the inside the endopouch has been taken out through a small opening there. That's why this laparoscopic management is regarded as cosmetic management or minimal invasive treatment. Some people call it keyhole surgery. That's a derogatory term for it, but and then it's out. I think we're left with 1 minute. Hunting down. It is exactly 19 hours. Formal greetings, ladies and gentlemen. The topic for today is advances in the management of ectopic pregnancy. My name is Dr. D.T. Mahapa, a urogynaecologist in Polokwane, Limpopo. I'm sure we will enjoy this talk with me together. The ectopic pregnancy, what is it? Ectopic pregnancy, by definition, is any pregnancy where the fertilized egg gets implanted or developed in any site other than the normal uterine cavity. Normally, when an egg gets fertilized, the development takes place inside the uterus. If the development of a fertilized egg develops anywhere outside the uterus, that pregnancy is said to be an ectopic pregnancy. If a pregnancy develops, this is the uterus, you can see. If it doesn't develop inside the cavity of the uterus, it develops anywhere outside, is regarded as an ectopic pregnancy. When you say ectopic pregnancy, we mean that. And then that's why a formal definition of ectopic is implantation of a fertilized ovum at any place other than the uterine cavity. An ovum is an egg. Then majority of this ectopic implantation happened in the fallopian tube. And if ectopic pregnancy implant inside the fallopian tube is called tubal ectopic pregnancy. We classify it according to the place where it gets implanted. Sometimes it implants on the ovary. If it implants in the ovary, we call it ovarian ectopic pregnancy. Sometimes it implants anywhere inside the abdominal cavity, far from the tube, far from the ovary, and is somewhere in the abdominal cavity. It's called abdominal pregnancy. It's another form of ectopic pregnancy. Very rarely it implants on the cervix. The cervix is the mouth of the uterus. It's not the inside the uterine cavity. It's regarded as cervical ectopic pregnancy. The tube has got a ligament which binds to the pelvic side wall, which has got a lot of areola inside. This ligament has got two layers. If ectopic aborts from the tube and implants in between the two leaves of the broad ligament, is said to be a ligamentous ectopic pregnancy. There are different types of ectopic pregnancies. If the number of ectopics nowadays, we see them increasing. There are many factors that make ectopic to increase, which we'll discuss now, like the birth control methods. Birth control method that prevent fertilization. It may reduce the number per 1,000 because it prevents fertilization, but not the number per delivery. Per diagnosed pregnancy or conception, the number will always be increased, but some birth control method predisposed to ectopic pregnancy. The reason why the number is increasing again is because improved healthcare services. Because improved healthcare services, it leads to people getting aware of the utilization of the healthcare services where ectopic can be diagnosed, rather than previously, when people used to die at home and we just attach all superstitious diagnosis to it while it's ectopic. People now use healthcare services more, so the incidence of ectopic pregnancy becomes more. We see a lot of women these days, because of reduced family size, they, after 2 or 3 children, they ask for tubal ligation, which is sterilization. But life changes. Sometimes the spouse passes away or divorced, she gets remarried, and she wants to reverse the sterilization. After reversal, the chance of ectopic increases. Another thing that makes ectopic more prevalent is that after tubal ligation, if tubal ligation is not done properly, it just damages the tube and predisposes it to ectopic pregnancy. A failed tubal ligation has got increased chance of becoming ectopic pregnancy than a normal pregnancy. So is reversal of sterilization. When a woman asks for to reverse sterilization, she must be counseled that she has got more than 30% chances that the pregnancy that is going to occur there is likely to be ectopic pregnancy, which means that's likely to be trapped inside the fallopian tube. The incidence of ectopic pregnancy, it increases. Recently, in USA and other developing countries, because of this utilization of healthcare services and improved healthcare services, it has increased 5-fold in the last 20 years. In the United Kingdom, it has doubled in the last 20 years. In India, it is said to be 1 in 100. But in our situation, the rate of ectopic is 1 in 250, which is very high. Ectopic pregnancy, I must say, is the leading cause of death in rural Black population, people who are far from health services, because if it ruptures while you are behind the mountain, the chances that you reach a facility where you will be operated or managed appropriately are very minimal. So it kills a lot of people who are staying far or remote from healthcare services. If one has had one ectopic pregnancy, it said that the chances that the subsequent pregnancy will also be ectopic is 15%. But if you have had 2 ectopic pregnancies in the same tube, your chances of having another ectopic in the other tube, it has doubled. It's about 25% to 30%. So a patient who has had ectopic has got more chance of having another ectopic, because factors that made it to have ectopic, they still exist. They might affect the other tube also. The history of ectopic says that it was first described by Albacasis in 963, before the birth of Christ. People knew about it long ago, before the birth of Christ. And in 1884, Robert Lawson Tate of Birmingham performed the first successful salpingectomy, the first successful removal of the tube, and saved the patient. The first successful ectopic removal was done in 1884, which is 3 times back. And in 1894, Bizarre in Paris also reported an ectopic pregnancy at a post-mortem of a prisoner. After the prisoner had been executed, he was sentenced to death. After executing that prisoner, probably it was a female prisoner, they did post-mortem and found that she had a ruptured ectopic, because majority of ectopic that were seen before that were all ruptured. In this prisoner, they found it unruptured. Strom, in 1953, very recently, all along, the management of ectopic was destructive, was just removal of the tube. He came with a method that we can save the tube and still have pregnancy. He did the first conservative surgery for salpingostomy. Salpingostomy means making an opening on the tube and remove ectopic and conserve the tubal structure, for in case hoping that the other pregnancy might occur from the same fallopian tube. In 1973, very recently, most of you were born, Shapiro and Adler, they performed laparoscopic salpingectomy. All along, it was done by laparotomy. They open the abdomen and do the operation. The minimal invasive laparoscopy started in 1973 by Shapiro and Adler, and they did salpingectomy, first successful salpingectomy that was reported. As time goes on, 1991, salpingostomy, removal of the tube, which means conservative surgery of the fallopian tube, was done laparoscopically by Young et al. In 1991, the first one, which is commonly done now. In 1996, I performed my first laparoscopic salpingectomy for ruptured ectopic pregnancy. The history beside this is that prior to 1996, a ruptured ectopic pregnancy was regarded as a contraindication for laparoscopic management. And I performed mine in 1996 and presented this in the International Gynecology Congress, where my abstract was nearly rejected. Mr. Johan van der Vaart, who was one of the assessors, actually phoned me and said, "Dendi, do you do these things?" I said, "I do them." And he had to come to my room in Pretoria. I show him the videos of ruptured ectopic done and I presented it. This is my first ectopic pregnancy that I did, which was ruptured. And I like this slide very much because this was a breakthrough. From there, it revolutionized the management of ectopic pregnancy. People no more say ectopic pregnancy. If it's ruptured, it's a contraindication to do laparoscopy. People just do laparoscopy. As long as the patient is stable anesthetically, we can do laparoscopy. This woman was ruptured, but was stable. So I did laparoscopic salpingectomy on a woman with a ruptured ectopic pregnancy. What causes ectopic? Etiology. There are many causes of ectopic. There's miscellaneous causes of ectopic. We have talked that there are some intrauterine contraceptive devices that prevents intrauterine pregnancy, but does not prevent extrauterine pregnancy. If you put up a loop, which is intrauterine contraceptive device, you will prevent the occurrence of pregnancy inside the uterus, but you will not prevent the occurrence of ectopic. So majority of pregnancies in the people with a loop in situ are ectopic pregnancy. People with endometriosis, a condition that damages the structure of the tube and tubal motility, it predisposed to ectopic pregnancy. Pelvic infection, people with repeated infection, vaginal infection, pelvic infection, it destroys the tube and it damages the tube such that the ovum motility is disturbed. The other cause which increases the incidence of ectopic pregnancy is assisted reproductive technology. Assisted reproductive technology like in vitro fertilization and gamete intrafallopian transfer. The pregnancy in those chances, they have got more than 10% chances of being ectopic than a normal pregnancy. Or I can say that any factor that causes delayed in transport of the fertilized egg through the fallopian tube, it favors the implantation in the tubal mucosa itself and giving rise to ectopic pregnancy. Like all those factors, endometriosis, PID, assisted reproductive technology, which is IVF and GIFT, IUCD, they delay the transport of the fertilized egg. These factors, you might be born with them, might be congenital. You might have congenital problem with the tube, or they might be acquired, but the majority are acquired, like infections are acquired. Endometriosis might be born to have it, genetic. IUCD is acquired, you put it there yourself. It was not there in you, you put it there yourself. And even assisted reproduction, you go for it. It's not a congenital thing. In that way that you must look at the patient's history and see it. This slide is a slide that I like the most. This woman came for reversal of sterilization because a family have changed. Now she wants another child. I did reversal of sterilization in Victoria. And she came after 8 months with a positive beta HCG, positive pregnancy test. And then I was happy. And I did an ultrasound, I didn't see anything. But she was having pain. When I do ultrasound, I discovered that she had fluid in the pouch of Douglas. And she had an ectopic pregnancy. But luckily, I canceled her that. After reversal of sterilization, the chances of having ectopic are increased. So I had to do salpingectomy and cut that tube and look at the contralateral tube because I had repaired all those old tubes. Luckily, God was with us. After a year, she came back again, and that time she had a pregnancy inside the uterus. This is how, if you do reversal of sterilization, warn the patient that you might have an ectopic. Some of the causes, the congenital causes, are tubal hypoplasia, the tubes that just develop and does not develop normally, and they're taught to us and coiled. Some have got diverticulum, which are pockets inside the tube, and the fertilized egg tend to implant inside those pockets. Some tube, usually every tube should have one ostia, one opening. If a fallopian tube has got accessory ostia, other openings, the chances that a fertilized egg will go in and lodge in that opening is very high. Some tubes are just born with some stenostic area for no apparent reason, she was just born with that. I've said that acquired ones are the things that you were not born with, you acquire them, like inflammatory condition. Sorry, people who have done abortion and abortion becomes septic, they've got a chance of damaging the tube and having ectopic pregnancy. Puerperal sepsis, sepsis after delivery. If after delivery you've got sepsis, that sepsis may accent and damage the tubal mucosa and cause intraluminal adhesions inside the fallopian tube, thus predisposing to development of ectopic pregnancy. Tubal reconstructive surgery, I have mentioned that I've done it and had an ectopic. Sometimes after sterilization, there's what you call recanalization. The tube recanalizes again. That's why some sterilization, even if well performed, it can also lead to pregnancy. But they call it a failed sterilization, not because the doctor failed to sterilize it. The tube recanalized. After recanalization, there's always a stenosis and fibrosis in the area of recanalization. And when the fertilized egg reaches that area, it might lodge there and not be able to pass to go into the uterine cavity. The tumors, like fibroids and ovarian tumors, might also disturb the tubal motility. If you've got multifibroid uterus like this one, and the tube is passing through this fibroid, it's likely to the fertilized egg to lodge there next to the fibroid, disturbed by the fibroid, and implant outside the uterus and cause ectopic pregnancy. These factors that I have mentioned, them salpingitis, pelvic inflammation, endometriosis, tubal surgery, diverticular, are all maternal factors. These factors are the factors that are in the mother. Most factors that predispose to ectopic are in the mother. They are not paternal factors. You can't say because the father is like this, she developed ectopic. The factors that predispose one to have ectopic are in the mother. And I've said some are acquired, some you are born with. If a woman has got a pelvic infection, she will have tortuous tubes like this one. And with tortuous tubes, you'll have adhesions between the tubes and other organs inside the body. And those organs, if there are adhesions, they'll disturb tubal motility. They'll disturb, if we can see this tube is adherent to the omentum there. So that it coils this tube, this tube is not straight. And when the egg is supposed to move in here, when it reaches at that corner, the movement, the peristaltic movement and ciliary sweeping movement get disturbed. Then implantation happens outside the tube. Let's see the ectopics, how by the size. Initially, when we started, we said if it's in the tube, it's called tubal ectopic pregnancy. In the tube, where can it be in the tube? In the tube, it can be one, in the femoral end, that's the beginning of the fallopian tubes. Two, it can be the ampullary area. Ampullary area of the tube is that widest area of the tube, which is called ampulla. And the thinnest, three, it can be in the thinnest. Majority of the ectopics, tubal ectopics are in the ampulla, followed by the thinnest area of the tube, which is called the isthmus, which is more muscular. And when the tube enters the uterus, that area of the tube is called the interstitial portion of the tube. It can implant also in the interstitial portion of the tube. Sometimes I said it can implant far from the fallopian tube on the ovary, either on the surface of the ovary or embed inside the ovarian stroma, destroying the whole ovary. If there is a congenital abnormality of the uterus with the accessory horn there, which is called a cone, and ectopic implants inside that horn, instead of implanting inside the uterine cavity, is called a conal ectopic pregnancy or a rudimentary horn, because this one is called a rudimentary horn. If the tubal ectopic is maybe most especially isthmal ectopic, it ruptures and it goes and implant on the omentum or on the intestine, somewhere inside the abdomen. It's called secondary abdominal pregnancy because primarily it was in the tube and the tube got ruptured. It implanted inside the abdominal cavity. Most people implant on the omentum and becomes secondary. But it's possible that primarily implantation might just be inside the abdomen, causing an abdominal pregnancy. We'll talk about abdominal pregnancy later on. This is a good indication of where the conal pregnancy is like, cervical pregnancy is like, on the cesarean scar is like, on the ovary is like. This is areas where ectopic can be, and each management depends on the area where it is and what the propensity of damage that can happen to that particular area. Like conal ectopic pregnancy can bleed a lot. Usually the management of a conal ectopic pregnancy, if it's advanced, will be removal of the entire uterus, because sometimes it's difficult to arrest bleeding if you've got a conal ectopic pregnancy. The same as if you've got an advanced cervical pregnancy, the treatment might just necessitate you to remove the entire uterus, because you might not be able to arrest bleeding if you can try just to extirpate the ectopic, hoping to preserve the fertility of the woman. Which means what I'm saying is there are some ectopics that, if they happen, is the end of fertility of that woman, the management, because the damage is so gross to the reproductive system such that you can't save it. Let's go to the types. We've repeated them. These are the types that I've told you about. The type that I'm very much interested in is what you call heterotopic pregnancy. Heterotopic pregnancy is an ectopic pregnancy, but there is an ectopic pregnancy outside the tube, but there's also a normal pregnancy inside the tube. It's a twin pregnancy where one baby is ectopic, one is a normal intrauterine pregnancy. It's called heterotopic pregnancy. We will discuss heterotopic pregnancy later. This is a picture of ovarian ectopic pregnancy. This is an ovary with an implanted fertilized egg inside it. That is an ovarian ectopic pregnancy. Usually the management of ovarian pregnancy is just ovarectomy. It destroys the ovary, and the ovary is so highly supplied with blood that you cannot suture properly and attain hemostasis. You might have to remove the whole ovary together with an ectopic, which is the optimal management. The type of ectopic that I called abdominal, more often they call it extrauterine pregnancy. Although all ectopics are extrauterine, but when they say extrauterine, they mean abdominal pregnancy, which is a very rare thing. But if it happens, it's life-threatening. It's a killer. The pregnancy implant in the peritoneal cavity, it can be ovarian intraligamentous, but if it does happen, although rare, it can bleed to some extent that a patient more often loses his life if it's not treated very early. Symptoms of abdominal pregnancy are not specific. They are like other symptoms, like abdominal pain. There are many conditions that cause abdominal pain. Appendicitis causes abdominal pain. Gastritis causes abdominal pain. Colonic disease causes abdominal pain. And it presents with nausea. Many women within pregnancy, they present with nausea. Even intrauterine pregnancy has got nausea and vomiting. The only thing is that if it's well advanced, you'll have easily palpable fetal parts. And the fetus will be malpresenting, either oblique or transverse lie. And when there's a fetal movement, it's so painful that pain of fetal movement cannot be accounted for by a normal intrauterine pregnancy. A normal intrauterine pregnancy can have painful movement, but these ones are severely painful. And if you do vaginal examination, the cervix is not central like a normal pregnancy. It's deviated to either side. It's either displaced anteriorly or laterally. That way we suspect a pregnancy is in the abdomen. And it can advance to many months, about 3-4 months, even up to 9 months. It can happen that you have abdominal pregnancy happening up to 9 months and you have a live baby. If we see the uterus is here below, the baby is developing inside the abdomen. And this looks like it's about a 20-week pregnancy. This I just want to show it very clearly with the uterus here and the baby developing here. Most extrauterine pregnancy or abdominal pregnancy are discovered late. Initially, they are treated as normal intrauterine, only late when the signs and symptoms like palpable fetal parts, displacement of the cervix, and the pain that is not cannot be that of intrauterine pregnancy. One does a thorough ultrasound and realize that this pregnancy is not inside the uterus, it's outside the uterus. And if it is the baby is still alive, with good care, you can have a live baby coming out of this. I'll show you one of the things that only last month in Mankweng we had an extrauterine pregnancy, which is a very special extrauterine pregnancy. We will see it as it comes. The broad ligament, I said, there are 2 leaves of broad ligament that covers the tube and go down on the lateral side of the uterus and join the uterus with the lateral pelvic wall. If in pregnancy occur between those two leaflets, you'll have pregnancy in like this one. This is intraligamentous pregnancy. One diagnostic feature thereof is that on top of that pregnancy, they will pass a round ligament, because the round ligament is a ligament that joins the uterus to the internal inguinal ring. It will pass there. The cervical ectopic pregnancy, as said, it implants on the cervix, on the cervical canal, where it must be proximal to the internal os. Cervical internal os must be closed, and the pregnancy must be proximal to internal os. If you look at the cervix here, the internal os is closed, and the pregnancy is outside here. More often, this pregnancy will dislodge if there is sex during pregnancy, because the penis will hit it and it will come down. But if it's not dislodged, for those women who look after their pregnancy, they abstain during pregnancy, it might grow to an extent that it can damage the cervix beyond repair, because the trophoblastic cells of the placenta will invade the muscularis of the mucosa and muscularis of the cervix. And after removal of this pregnancy, you end up with a condition called incompetent cervix, a cervix that doesn't close well, a cervix that cannot retain a normal pregnancy. So more often, if it's well developed and the cervix is destroyed, the best thing is just to remove the entire uterus, because that woman will never have a baby anymore. The heterotopic pregnancy, I've said, I've got a love for this, because only last month in Mankweng Hospital, we had a heterotopic pregnancy that we progressed up to 36 weeks, and we delivered 2 live twins, which have no congenital abnormalities. It's heterotopic pregnancies, intrauterine pregnancy and ectopic pregnancy coexisting together. One pregnancy is inside the uterus, one is outside. That's what you call heterotopic pregnancy. And this may be homopaternal or heteropaternal. What do I mean? If I say homopaternal, it might be from the same man. May say the woman is polyovulated. She ovulated 2 eggs. And the same man fertilizes both eggs. But another egg implant inside the uterus, another egg outside. And it can be heteropaternal. Heteropaternal means 2 male. Say, for example, the husband fertilizes, the woman polyovulates. She polyovulates more than 1 or 2, 3 eggs. And the husband fertilizes 1 egg. Tomorrow, whenever they are at work, the woman with another man, they do whatever they do, that other man fertilizes the other egg. Then it can be heteropaternal. And more often, the one that implants in the uterus first is the one that will implant. Once implanted in the uterus, all other eggs that are implanted will be barred from going to the uterus, will become ectopic. So the ectopic heterotopic is the second implantation. It's always the second fertilization. That's why they say sometimes heterotopic pregnancy occurs because of superfetation. Superfetation is a situation where a woman gets fertilized while already pregnant. Let me explain it this way. The woman is pregnant, say 4 weeks pregnancy with intrauterine pregnancy. And because of the placental hormones, the pregnancy hormones are not high enough to suppress ovulation. Then 2nd month, she ovulates again and get fertilized. That is called superfetation, means you get fertilized while you are already pregnant. That's why it can be homopaternal or heteropaternal, because you might be fertilized by this man this month. Next month you ovulate, another man fertilizes you. Then it becomes heteropaternal. Or it can be to superfecundation. Superfecundation is a condition that I explained before, that a woman polyovulate and the sperms fertilize, one sperm fertilizes another egg, one fertilizes another egg. The other egg implant inside the uterus, while the other egg implants outside. So, but it's not difficult, it's not easy to say this one was due to superfetation or superfecundation. These are just the method by which you can have heterotopic pregnancy, where you have got a pregnancy inside the uterus and a pregnancy outside the uterus coexisting at the same time. On ultrasound, early, if you do ultrasound very well, you can see a well-circumscribed sac inside the uterus, which is with a fetal bone, which is ectopic pregnancy. And then outside, if you look very well, you can see an ectopic pregnancy. So it is important to, when you do ultrasound and you diagnose a pregnancy, to also to look outside whether there are no other pregnancy, whether there are indices or clues to that or not. More often, the pregnancy is not a painful condition. Early pregnancy is not painful. If pregnancy is associated with pain, you must have a high index of suspicion that there are either another pregnancy outside. Although there are many other conditions that can cause pain during pregnancy, like infections, but look for a gestational sac outside. If you find it, you're lucky, you can treat it. If you don't find it, if it ruptures, it can be catastrophic. When you see at this slide was taken last month, April, in Mankweng. This is the normal uterus, which had a baby inside. We've just removed the baby here. These are my hands here. And that one is a pregnancy, intraligamentous pregnancy. This is the leaflets of the broad ligament. There's a baby inside there. So we remove the intrauterine first and later remove the extrauterine pregnancy. If you look, when we entered this patient, we were faced with the ectopic pregnancy, the heterotopic one, with a lot of blood vessels pumping from very varicose blood vessels on the surface of the broad ligament. And we had to extend the incision so that, being afraid of rupturing this one first, because we didn't know how it's going to bleed, because this can bleed, hell can bleed. So we had to attend first the intrauterine and extrauterine. And for us to go to the intrauterine first, we had to make the incision bigger so that we mustn't disturb this one. If you look at here, after incision has been extended, this is the uterus with the baby inside. That is the broad ligament interstitial pregnancy with a baby inside. This is a heterotopic pregnancy. This is an ectopic pregnancy. And we decided there's no proper way of saying manage this one first. What we decided is better to remove the baby who's in the uterus first and close the uterus and face this mammoth that we didn't know how it's going to behave. And what we did here, because of a lot of these blood vessels, we removed the baby and left the placenta inside for 72 hours so that the vessels can subside in size. And after 72 hours, we went there. More often, the book says the placenta will just come out easily. It was not easy. We had to remove the whole adnexum together with the tube, the ovary, and the placenta together, because it has implanted so much inside the broad ligament that you couldn't just remove it like a placenta in the uterus. But luckily, the patient and the baby went home well with twins, and the contralateral tube that we had here was normal. We hope this patient will also have another baby. Clinical signs of ectopic pregnancy. Okay, it can present as an acute condition. Suddenly, the woman in the morning was well. Suddenly, in the afternoon, she's such a sick patient. Or it can be chronic. Gradually, the woman feels pain becomes worse and worse. After 4 or 5 days, she feels, I need to go to the hospital. There must be amenorrhea. There must be a missed period. She must have missed a period. Amenorrhea means lack of menstruation. She must have said, I missed my period 1 month or 2 months. And with that missed period, there will be abdominal pain, which may be dull, it might be sharp, it may be colicky, it might be localized or diffuse. There's no specific type of pain that we can say this pain is typical of ectopic pregnancy. It can take any form of pain. A pain can be dull, can be sharp, can be colicky, can be diffuse, can be localized. Then, if in some cases, if it ruptures and bleeds heavily, the first presentation is just collapse. The woman just collapses because of bleeding inside. If you ever get a woman, whether you know that she's pregnant or not, who just suddenly collapse, don't think of epileptic and other things. Look at the mucous membrane. If she looks pale, the pulse is steady, the chances she's bleeding inside, it might be an ectopic pregnancy. And if it's far from area where help can be found, unfortunately, the chances are that we might end up with a corpse. That's why I said in my introduction that it is the commonest cause of death in women, in rural women, because they are far from hospitals. And more often, when ectopics start bleeding or dying, the endometrium inside the uterus starts to slough off. Then she starts bleeding vaginally. And more often, in a thin woman, you can palpate a pelvic mass, which is an ectopic, which is tender, which is painful. What is the pathology of ectopic pregnancy? There is trophoblastic proliferation in the lumen of the tube. Trophoblast can be both trophoblast, the cytotrophoblast and syncytiotrophoblastic, which invade the mucosa of the tube. After it's gone through the mucosa, it will reach the basement membrane. It goes through the basement membrane again, and you find that areolar layer, which is called lamina propria, which is called blood vessels and lymphatics. And it invades the blood vessels. That's why bleeding usually happens, because the lamina propria has been reached by the proliferating trophoblastic cell. Then from there, it attaches on the muscle layer, the muscularis. Attaches on the once it's attached there, it starts to form a thick mass, and the serosa, which is the serous surface which covers that things like plastic which covers the tube, it gets distended, and it's highly supplied with nerves. That's where pain comes from. Pain comes from stretching of serosa, because the bleeding distends the serosa and cause pain. And if bleeding becomes severe and distending, will result into rupture. And once rupture occurs, the bleeding occurs. Bleeding happens inside the abdominal cavity. That's why I've got syncope. And the blood will also go onto a dependent area. The dependent area in an upright person is the area called pouch of Douglas, which is an area behind the uterus. And so when you do ultrasound, you find fluid behind the uterus. You suspect this might be an ectopic pregnancy. What I've been saying in the pathology is that it went through mucosa, the submucosa, the basement membrane, the areolar layer here, which is called lamina propria, and then it finds a smooth muscle layer here until it reaches serosa and ruptures the tube. That's how pathology of the endometrium is. When the pathologist look at that, he looks at those things. On microscopy, when the pathologist will give him a specimen, he must see the trophoblastic cells. Trophoblast, both syncytio and cytotrophoblastic cells. And chorionic villi, he must also see the chorionic villi. Trophoblastic cells with chorionic villi within the tubal wall is diagnostic of ectopic pregnancy. If during ectopic pregnancy, as usually most people do, you do uterine curettage, you do a DNC during ectopic pregnancy, the endometrium, the pathology will find endometrial proliferation, which is atypical, which cells which are enlarged, which are hyperchromatic. Hyperchromatic means nuclei which are very dark, and pleomorphic. Pleomorphic means they have got different shapes. The morphology of the nuclei are of different shape, and some has got mitotic activities inside, with mitotic divisions inside. There's mitosis taking place inside the nuclei. This phenomenon is called decidualization of the endometrium, and it will be without chorionic villi, because chorionic villi you can only find them where there's been an ectopic, because here ectopic is outside where there's been a fertilized egg, because fertilized egg is outside, inside the endometrium, you just find decidualization without chorionic villi. And that phenomenon is called Aria-Stella phenomenon or Aria-Stella reaction. The pathologist will tell you that I see Aria-Stella reaction. What it means there's decidualization of the endometrium without chorionic villi, which is Aria-Stella reaction. The Aria-Stella reaction on pathology is like this. You see the nuclei, I said, they are dark, hyperchromatic, like this one is dark. And they are pleomorphic. You see these nuclei are different sizes and shapes. They are of different sizes and shapes. And in some nuclei, like this one, you can see it's divided. There are mitotic activities. There's mitosis take place in there. It's like in a tumor, but not all nuclei are in mitotic. In malignant tumor, all nuclei will have mitotic. But here there will be some with mitotic, some without mitosis. It is said that a pregnancy in the fallopian tube is like a black cat on a dark night. You can't see a black cat in a dark night. This black cat, it may be felt, its presence felt in a subtle way and leap at you, or it may slip past unobserved. You might pass a black cat here, not knowing that it's a black cat. Same as ectopic. You might examine a patient and think she's got PID, she's got appendicitis, she's got just a stomach ache, and miss an ectopic very easily. It said that although it's difficult to distinguish a black cat from other cat of other colors in the darkness, illuminating clearly identifies it. What they mean is that although it's difficult to differentiate pain of ectopic from pain of other causes, but with thorough investigation and examination, you can come with a proper diagnosis. That's McFarlane who said that in 1991. What I say is, what it all means to me, it means that you must have a very high index of suspicion of ectopic wherever a woman in the reproductive age with a period of amenorrhea who have missed period presents to you with atypical signs which includes pain. You would rather have a negative laparotomy. You go and do a laparoscopy and come out negative rather than to miss an ectopic pregnancy. I think to miss an ectopic pregnancy is a worse sin. It's rather to take the patient to theater and come back and say it was not an ectopic. That can be forgiven, but you can't be forgiven for missing an ectopic pregnancy. For example, if a woman has got a small ruptured ectopic pregnancy, like this one, and you do an ultrasound, you see little fluid like that blood in here. You think it's fluid that's usually there when the patient has got pelvic infection. And that ectopic is more or less the size of an ovary. You might think it's an ovary or it's an intestine, and miss it very easily if the pain is not so worse. Because surprisingly, women can tolerate pain, unlike men. They don't just come agonizing, but can tolerate pain. So they can fool you. And like if it ectopic could be in a man, I will diagnose it very easy because men can tolerate pain. The high index of suspicion and good investigation and examination will lead to the diagnosis of ectopic pregnancy. These days, in spite of an increase in the incidence of ectopic pregnancy, there has been a fall in case fatality. What do they mean? They mean that although the number of ectopic diagnoses are increased, the mortality, people dying from ectopic are less. This is a statement. And this statement, I don't think it applies to us, but worldwide, in first world and second world country, this statement applies. To us, I don't think we can say that the mortality of ectopic has gone down, because this reduced mortality is due to widespread introduction of diagnostic tests and increased awareness of seriousness of this disease. Is there increased awareness of the seriousness of ectopic in South Africa? It's not something that public health experts really, even the government doesn't preach it very much. Because one of the things of ectopic, I told you that is septic abortion. And we have got a rule that legalizes abortion. And we do abortions in a very aseptic way. So we are the cause of septic abortion. So that statement applies worldwide. But to us, we have to make sure that it might not be the case that our cases are low. The increase in diagnostic tests has resulted in early diagnosis and effective management. We have diagnosed them very early and manage them very effectively. What is the commonest, the first line of consultation when a woman has got a pain in a normal African family? One would say a doctor, but I would say the first diagnosis is the local inyanga, who will give you some muti to put under the tongue. By the time it simply becomes worse, it goes to the clinic. It might be very late. That's why public awareness is very necessary in this case. The rate of tubal rupture worldwide is about 20% now, even in the United States. But that case cannot be the case in South Africa because tubal rupture happens because a person consults very late. And our people, besides being consulting very late, they stay far. Our health facilities are so widely spread, far apart. If a woman from Amalwo have an ectopic Amalwo, by the time you get transport to come to Bochum Hospital, it's already about 18 hours, if not more than 24 hours. That way, consultation will be late and rupture is likely to occur. And if there's torrential bleeding, that woman might not make it up to the hospital. I included here because this talk, I'm talking to South Africans and say why South Africa still has high fatality rate after 1994. When 1994 was like the coming of Messiah, we thought things are going to change, Why is still like that? Because we came with a referral pattern. We, the government, came with a referral pattern, which is Western apartheid referral pattern. In apartheid, it was nice. Blacks go to that hospital, whites go to that hospital. And the hospital that blacks go to, although they were designated and separate, they would get help. Now everybody goes to the same hospital, but the quality and quantity of help is reduced. The referral says that if you are sick, you must first go to the clinic, and clinic must refer you to a regional hospital. Then the regional hospital can refer you to district hospital, where then you can get facilities, because most of our regional hospitals don't have facilities, don't even theater facilities or anesthetists or anything that can help an ectopic pregnancy. We haven't prioritized that a patient with an acute condition like ectopic, when he's got ectopic at Amalwo, he must come straight to Polokwane. He mustn't go and delay at Bochum Hospital, what is the name of Island France Hospital, before he comes here, because there they will keep him for some hours before they refer here. And by that time, the condition is worsening. And this has resulted, another thing why mortality is high. When people start to get sick for the first time, they don't consult our health facilities. They look for other alternative medicine because people have lost confidence in the health facilities. Usually, if you look at any region, the hospital near that region is not trusted by the people, the community that surround that region. When I talk, they call it Rebuile. There's a Rebuile phenomenon. Every hospital, the village around it, they call it Rebuile. I don't know why. What can we do to remove this Rebuile phenomenon so that people can have confidence in their hospital? And there's only way, if we can just uplift the quality of healthcare in the hospital, people will have confidence in that. So in summary, the rate case fatality in ectopic in our situation is high because there is a generalized decline or deterioration in the state of healthcare services, period. That cannot be doubted. What are the methods of early diagnosis of ectopic pregnancy? There are various methods that you can diagnose and various tests that you can do. The commonest one, what you call home pregnancy test, which is an agglutination inhibition assay test, which is sensitive with the urinary chorionic gonadotropin up to 200 milli-international units per liter. If below this, the home pregnancies that will not pick up the pregnancy, whether they're pregnant or not, which is an agglutination test, but it's most accessible and more cheap. The second one in sensitivity is ELISA, which is enzyme-linked immunoassay utilizing monoclonal antibodies to the beta HCG. The human chorionic gonadotropin has got two subunits, the beta and alpha. We check at the beta subunit of human chorionic gonadotropin. And the ELISA can pick up to 25 milliliters per mil. Very, very sensitive. But the most sensitive is the radioimmunoassay, which is called RIA. RIA can pick up the beta HCG up to 10 milli-international units per liter. But all these tests, they go with agglutination test that says is the cheapest. ELISA is more expensive than agglutination, and RIA is worse expensive than that. So people tend to use a cheaper one, and which is more sensitive, which is less sensitive than an expensive one. But that's why if beta ECG, a woman you send the laboratory, they say beta ECG is negative, and you think she has got ectopic pregnancy, ask them what assay are they using, what test are they using. If they say agglutination inhibition, repeat it after a day or two, because it's not so sensitive. But if they use the RIA, chances are that if it's negative, it's negative. If it's positive, it's positive. That's why sometimes we get a false positive beta ECG, because we are using a less sensitive agglutination test. The transvaginal sonar can visualize a gestational sac, ectopic gestational sac, at about 4 to 5 weeks, which is the time when a woman realizes that I've missed period. It's very sensitive. During that time, the beta ECG level is about 2,000 international units per liter, which means agglutination test can pick it up. So if sonar shows you that there might be an ectopic, urine test will be positive. If beta ECG level at that level, if it's not ruptured, and you still have doubt whether it's ectopic or it's another thing, take beta ECG level after 48 hours. If beta ECG after 48 hours doesn't double, it's ectopic, because at early pregnancy, the beta ECG value, quantitative one, it doubles every 48 hours in a normal intrauterine pregnancy. If it fails to double, it just increases by 1.5 or by 1, it's not ectopic pregnancy. This is a picture of ectopic, early ectopic, that you can see on ultrasound with the pregnancy outside the uterus. This is the pregnancy outside. That's the uterine cavity. The endometrial cavity, which is decidualized, is seen clearly here, and this pregnancy is outside the uterus with the yolk sac seen here. Maybe the fetal pole will develop outside the yolk sac, but inside the gestational sac. So a demonstration of a gestational sac with or without live embryo outside the uterus is diagnostic of ectopic pregnancy. And that sign is called Beckel sign. The gestational sac appears as an intact, well-defined tubal ring by 4 weeks when it measures 5 millimeters in diameter. If you go back, you can see that this is a gestational sac at 4 or 5 weeks, which is a well-defined sac outside, which can see by transvaginal sonar. Even abdominal sonar can see it in a thin woman. But if a woman is a bit increased BMI, the abdominal sonar might find it difficult to penetrate that abdominal fat to go and give you a good picture. After you have seen that, it can be seen as a complete sonolucent sac with a yolk sac and an embryo pole with or without heart activity. More often, sometimes, in here, you can see the fetal pole outside this yolk sac. And if you do a Doppler very well, you can see fetal heart activity, which means we can have a live baby inside the ectopic and see it very well that this is a live baby inside an ectopic. So when you do sonar for ectopic, look around everywhere. See, there's an ectopic pregnancy here. That's the uterus outside there. And look around everywhere. Then you will find that the uterus will be seen separate from the ectopic pregnancy. The urinary beta ECG, ultrasound with fluid in the pouch of Douglas, is indicative of ruptured ectopic pregnancy. Positive beta ECG and fluid in the pouch of Douglas and empty uterus makes a diagnosis of ectopic pregnancy. To confirm it, if your sonar has got a Doppler effect, you can do a color Doppler on the placenta, which is outside. You'll see a typical characteristic diffused sonolucent characteristic, which is called fire pattern, can be seen outside the uterus, which indicates that there is life outside the uterus. And that will be an ectopic pregnancy. How do you manage it? Problem. It's good to know how to diagnose. If you know how to diagnose, it's good, but how are you going to manage it? You must also know how to manage it. It depends on the stage of disease and the condition of the patients at the time of diagnosis. Some patients come stable, some patient comes very sick. So the very sick and the stable one cannot be managed the same, but there are several options. One option is that you must do surgery, you must operate. Either do laparoscopy or do laparotomy, depending on the stage of the disease and the condition of the patient. If the patient is stable and you happen to diagnose it early, you can administer a drug at the site of ectopic, cytotoxic drug there, which is called medical administration, and kill the ectopic there and leave it there without operation, which you can do by ultrasound or by laparoscopy. Another one for medical students, because there are medical students in this presentation, method, the book will tell you that expectant management. Expectant management is if the patient is stable, just observe and see how far the patient will go. That I put it in red is a very dangerous method of managing ectopic. Never practice that, because should it rupture after 4 days, you have discovered the ectopic and you keep it in the ward, you say one expectant management, and she ruptures during the night and die, you will regret for the rest of your life. Why didn't you intervene early? Expectant management, I mention it here just to discourage it. There's some other things that we'll find in the textbook that might just be managed only to be condemned. There's no place for expectant management of ectopic. It's like seeing a bomb there. You've seen the bomb, that's a bomb. You say, one method is just to look at it and see if it doesn't explode, just leave it there. We'll see what will happen. What if it explodes? Manage it appropriately. I've said that the best management is if it's ruptured and tube is damaged, is salvagectomy. And I always do mine laparoscopically. Like you see this tube is damaged, is ruptured. I tied it up and I'm going to cut it and remove it. And the woman will remain with one tube, but will be alive. The one tube, it means it reduces his fertility potential, but you'll be alive. You will save the life, although you might compromise fertility. But if you don't remove the tube also, you don't increase fertility. It boils out to the same thing. So the management of ectopic pregnancy, again, depends on the desire for fertility of that woman. You must ask her, does she still want to have more children? Or she doesn't want any other children? If she wants to have more children with no child, you must be very careful, try to be conservative and try to restore fertility. And always look at the other tube, the contralateral tube, and the status, and see if I cut this other tube, will that other tube be able to conceive? If the other tube you think is also severely damaged, try your best to try to preserve this other tube also. There are various methods of preserving the tube that I'll discuss later. And that will depend on the surgeon's ability to use specific instruments in managing those tubes. Usually they are microsurgical instruments that you use to preserve the tube. If ectopic is ruptured, the management is simple. Firstly, hospitalize. Any ruptured ectopic must be admitted and hospitalized. And you resuscitate, order blood, treat the shock, and the patient must lie flat with the legs raised so that there must be blood flow towards the head. Increase the blood flow to the brain so that she mustn't collapse, she mustn't faint. And we give analgesia. Analgesia, it reduces pain, it reduces anxiety, and it also treats the neurogenic shock that might be there. When you resuscitate, we treat hypovolemic shock. But because she's scared, maybe she heard that ectopic can kill, she'll go into psychogenic and neurogenic shock. And always order blood, because you might need to transfuse her with blood before or after the operation. Another method in rural, if the laboratory methods are not easily accessible, you can't get the results, you've done ultrasound, you see fluid in the pouch of Douglas in that dependent area. You do what you call coldocentesis. It's most helpful in emergency situation at casualty to confirm the diagnosis, where you find that you've got free flowing blood. The blood of coldocentesis, even if you put them there, it doesn't clot. Blood that doesn't clot. Normally, if we take a blood from a patient, in 7 to 8 minutes, it must form a clot. But that one doesn't clot, even if we put it for hours there. Non-clotting blood diagnostic of ectopic pregnancy. But if you do coldocentesis and you don't come with blood, it's not conclusive, it's not diagnostic, because sometimes the needle might just go where there's no blood or the needle is clotted. And sometimes, so the value of coldocentesis in making a diagnosis, although it's helpful, it's still controversial. You can't rely on it alone. You can just confirm other things, because there are a lot of other things that can give you a positive coldocentesis, like a ruptured corpus luteum. Fluid blood can go there and you have got positive coldocentesis. If somebody has done coldocentesis previously and ruptured a vessel, and you go into there, you'll find bleeding, blood from that bleeding that caused by that previous person, and you think it's ectopic pregnancy. And sometimes maybe tubal abortion can give you that. This is a picture of coldocentesis. You've got the uterus here, the blood will accumulate here. You go with a needle here, you aspirate here, and put it in a test tube and see if it can clot or if it doesn't clot. If it's free flowing, doesn't clot, that is indicative of ectopic pregnancy. And I must stress that laparoscopy or laparotomy must be done as early as possible before the woman is shocked. And when you do laparotomy or laparoscopy, do not remove the ovary on the other side of the ectopic together with the tube. This I mention it because there's the teaching that was propagated by Mr. Jeff Coate that you must also remove the tube. And earlier gynecologists used to remove the tube. The benefit being that they say, Jeff Coate was saying, if you remove the tube with the ovary, then you are sure that ovulation that will occur next time will be from the tube, from the ovary on the side of the normal tube. That has proven not to be scientifically correct. If blood is not available in your institution, you can use the old patient's blood to transfuse, which is called autotransfusion. Surgically administered medical treatment, which is called SEM, is a medical treatment where you put a cytotoxic agent on the tube and kill it. And I'm stressing that expected management, I mentioned it for the medical students. If you ask about it, you can mention it as part of management. But clinically, in clinical application, it's my view that never practice that. It's very dangerous. It's risky, usually it's risky. Treatment of ectopic is always surgical. No expected management. And if it's ruptured, remove that other tube. The offended tube, salpingectomy. If there's blood which is infected in there, make a hole in the posterior cul-de-sac and drain the pus or drain the blood there. The patient will be alive. Do not remove the ovary together with it. Because that takes home message. Do not remove the ovary together with it. Surgical treatment, I said, can be either laparotomy or laparoscopy. Salpingectomy or salpingostomy, who can do it. There's another method. They say that if the ectopic is distal next to the ampulla, you can milk it out. If you milk it out, the study has shown that if you milk it out, it heals with fibrosis and causes tubal block and hydrosalpinx. That will damage the tube permanently. So never milk it out. Do a nice linear salpingectomy. Open the tube, remove the ectopic, and suture it by primary union, or you can leave it to heal by primary union, or you can leave it to heal by secondary union. It doesn't matter. It depends on your choice, but it's always either laparotomy or laparoscopy. SEM is not what you should do. Now the controversy comes on which one is the best, laparotomy or laparoscopy. When you look at some indices, the hospital stay, laparotomy will stay 3 or 4 days in the hospital. Laparoscopy probably can go home the same day or the following day. So the number of hospital stay in hospital cost, laparoscopy is less. And the formation of adhesions, laparotomy will give you more adhesions, laparoscopy won't give you adhesion. The risk of future ectopic is the same in both. The future fertility is the same in whether laparoscopy or laparotomy. It is the same. And the laparotomy, it just needs a surgeon to be trained. But laparoscopy is not only training, it's a special training that you must be trained in the use of laparoscopic instruments. So it's not everybody who can do laparoscopy management of ectopic pregnancy, because instruments are not just general instruments, general surgery instruments. There are specialized instruments that you must be taught how to use. So all tubal pregnancy can either treated by total salpingectomy if it's ruptured. Salpingostomy only indicated when the patient desires to conserve a fertility. She doesn't have children, she still wants to have children. And that patient must be hemodynamically stable. And the pregnancy must be easily accessible. It mustn't be embedded inside adhesions or trapped in the pouch of Douglas. And it must be unruptured and less than 5 centimeters in size. Of course, if it's more than 5 centimeters in size, it will be ruptured in any way. And you must force yourself that you want to conserve this tube if the other tube is absent or damaged, because if it's severely damaged, you damage the other tube. You have sterilized that particular woman. The choice of surgical treatment does not influence the post-treatment fertility. Whether laparatomy or laparoscopy, it doesn't influence the treatment fertility. If the woman had prior infertility before, whatever method you use, she will still remain infertile and will need to be treated like an infertile patient, sometimes with assisted reproductive technology. There was a scoring system that was done by a man who said you can score the tube, score the adhesions, and predict what the chances of having a baby in that. What are the chances of having a baby in the woman who does that? But that scoring is not always easy to score, and it's not without problems. The rationale is that if the woman doesn't have adhesions and she desires pregnancy, conserve the tube. But if she doesn't desire any pregnancy, because conservation of the tube in instance of ectopic, remove that tube. Like you see this woman, she has got 3 children. This was the 4th child. It's an ectopic and she's satisfied. She says she doesn't want any other child. What I did here, I cut that tube, because if I had conserved that tube, I will be increasing the chance of being ectopic by about 20 to 30% in subsequent pregnancy. In a woman who has got 3 children, who has told me that I don't need any more children, even this pregnancy, it surprised me. I wasn't planning, it was not unplanned pregnancy. So this management usually always try to be aggressive, but your aggression must be coupled with discussion with the patient with desire for future fertility. Whether you do laparoscopy or laparoscopy, it doesn't matter. The instruments I've said laparoscopy, they are specialized. It can be carboxylic CO2 laser, can be argon, which is called argon beam coagulation or ABC, can be scissors, can be point needle, can be diathermy. There are many instruments that you can use in trying to do salpingostomy or salpingectomy laparoscopically. But I just want to show you here how to do laparoscopic salpingostomy, and you look at it, how it's done, and it looks easy, but actually it needs well-trained person. I think our children will be very good at laparoscopy because they play these games, these video games, so their hand-eye coordination are better than us, because we struggled because we were not playing with video games. We were playing with empty polish containers and the donkeys excreta to make cars and the wires to make cars. So our hand-eye coordination is not as good as our children's hand-eye coordination. These video games, they teach them good hand-eye coordination. You see that ectopic on the antimesenteric border, coagulation is done there. The coagulation will minimize bleeding. Here is using a laparoscopic monopolar hook. And with a laparoscopic monopolar hook, in a cutting mode, you can cut with minimal bleeding and make an opening there. Once the opening is there, you can milk the ectopic out. That way you preserve the tube, and you can use laparoscopic Babcock to milk the ectopic out. And after milking the ectopic out, you can subject it, you can take it for diagnosis for confirmation. You put it there, you'll remove it later. If there's some bleeding on the fimbriae, also removed. And make sure that you remove everything inside there. And check again whether there's not something remaining. If there's something remaining, remove it again until you remove everything. That opening, you can either leave it open like that, it will heal by secondary intention, or you can suture it microsurgically. It doesn't depend. It depends on your skill and what you prefer to do. In that way, you have preserved this tube, but know that you've got 20 to 30% chance of having repeat ectopic in the same tube, and maintain hemostasis. To give you that tubal pregnancy, you can either suck it or milk it out like I've shown you, and make sure that the bed is free of, it's not bleeding. You can leave the opening open, or you can close it. I've said, depends on your anesthesia. It doesn't matter you leave it open or not. Then if you leave some products inside there, you'll have a condition called persistent ectopic pregnancy. That trophoblast that you leave there will keep on dividing and sometimes can even rupture and cause torrential bleeding. That's why it's important to remove everything and follow up with cytotoxic agent like methotrexate, which is a treatment that we used to treat for choriocarcinoma, placenta which is left in situ, so that methotrexate can digest as an antifolate, digest that whatever remnant of trophoblast which is in there. Or you can use systemically administered medical treatment. You use things laparoscopically or by sonar. You can put things like actinomycin D, which is an anti-cancer agent, which is used to treat ovarian tumors, mifepristone, which is a good drug for cause abortion, or methotrexate. Potassium chloride is also being used, but be careful. If potassium chloride can go intravascular, it can cause heart block. So be careful of using potassium chloride. But basically, it's mentioned as one of them. But if you inject it inside the blood vessels, the heart will just stop. Or you can use hyperosmolar glucose. There are many other drugs that you can use medically to dissolve that. But methotrexate in itself, it was first used in the treatment of molar pregnancy. It interferes with DNA synthesis and synthesis of pyrimidine, and it causes trophoblastic cells to die. So that way you kill the trophoblastic cells. And for you to use methotrexate, you need a pregnancy less than 3.5 centimeters. And you give it at a dose of 50 milligrams per meter squared daily with folinic acid, or you can give it weekly without folinic acid, because it's the antifolate, it will cause anemia and other GIT symptoms. So you give folic acid to counteract those side effects. And the textbook will tell medical students that when you treat with methotrexate, it's usually an outdoor treatment. You can treat as outpatient. I'm telling that it's risky. Admit that patient and treat it inside the ward, because there's a case of trophoblastic rupture, even if the patient is on methotrexate, that it can rupture and bleed at home. So the side effect like GIT and skin, you can counteract by folinic acid, but always admit the patient. Don't treat the patient as an outpatient, because one other thing, every patient's outpatient. I'm not sure that she's going to come every day. One day she's not going to have money to come to the hospital, and she's going to default. And if she's default, who else is going to be blamed? Not the patient, yourself. I said expected management, where you just watch and see, hoping that it will abort or resolve by itself. Before salpingectomy, before 1884, the mortality in expected management of patient was 70%. So you cannot do a treatment which has got a 70% chances of the patient dying. They say today is done in selected cases. What selected cases? Every case must be treated on its own merit. So this expected management, I mention it here. Medical students can put it in their exam, they'll get right, but practicing practitioners don't do that. It's a risk. Actually, it's stupid to do it, to see an ectopic and say, I'll manage it, explain it. Because the tubal pregnancy have been known to rupture even when the serum beta HCG is going down. I've given a good example and say, you can't see a bomb there, which is not exploding. and not detonate and say one method is just to expect it, just to look at it and see if it doesn't explode, just look at it there. What about the day it explodes? It might kill you. So once you see a bomb, get the bomb specialist. In summary, ladies and gentlemen, the key point, the incidence of ectopic pregnancy is rising while maternal mortality is falling globally. And again, early diagnosis is the key to less invasive treatment. The later the diagnosis, it's going to involve more invasive treatment. Usually there's tubal rupture. The choice of treatment is either laparoscopy or laparotomy, but I personally prefer laparoscopic management. The trend today is towards conservative management. That must be discussed with the patient, whether she desires to be pregnant or not. Does she still want other babies or not? Majority of patients with ectopic pregnancy, they've got a history of infertility, they've got pelvic infections, they've got endometriosis, they still want babies. So one should practice to be conservative. Proper counseling of the patient and monitoring is mandatory. You must counsel the patient. Don't give the patient false hope that you are the super doctor who's going to have babies. You're going to have babies after this. Don't promise things that you cannot. Only God can promise those things. Just tell the patient the truth that chances that you can have a baby are there, but they are very less. Ruptured ectopic should be unusual in a compliant patient and appropriate medical care. If our medical care, our hospital, our system are good, and patients are well educated about ruptured ectopic, about ectopic pregnancy, it shouldn't become rupture because it has early signs before rupture, which is pain. When there's pain, people should not consult people who cannot treat ectopic appropriately first. The first line of event should be the hospitals for treatment and early diagnosis being done. That way, you can reduce the death rate from ectopic. The take-home message in this talk is medical management, expectant management, milking of the tube are just mentioned here just to be condemned. It's part of the management that the medical student will read that, but do not practice those things, are dangerous. Do salpingostomy, salpingectomy on those patients. These are not for third world treatment. Ladies and gentlemen, this marks the end of our talk, and thank you very much. I want to go there and allow you to unlock yourself, unmute yourself, and we can ask a few questions and take questions. So, before, when you ask questions, go to, on your thing, you go to, where do you go to raise your hand? Controls. It's not the remote control. Why am I forgetting to guide you? You must raise your hand so that I can see you and allow you to talk. I see we are left with 46 participants. Do you know how to raise your hand? Let me make it this. Samsung MG. Samsung MG. Samsung MG has raised his hand. Let's hear you. Can you unmute yourself?
Oh, good evening. Am I audible?
Yes.
Okay, doctor. Thank you so much.
Say your name. Say your name, my darling. Say your name.
Okay, my name is Vanessa.
Vanessa, good afternoon. Good evening.
Good evening. I had an ectopic pregnancy in 2021, and then it was treated laparoscopic surgery. And then in 2022, I was pregnant and I delivered this year. But the doctor told me that I have a tumor, like a fibroid, but it's not inside the womb, it's on top. So I want to know, if I were to conceive again, must I go for an operation before, or because my baby was very tiny, she was 2 kg when she was born.
You know, if you have got fibroid, whether it's ectopic sign or not, as time goes on, fibroid is also growing. Chances are that by the time you fall pregnant again, that fibroid will be bigger than it was before when the doctor did cesarean section delivery. So
there's no way it can shrink. It will remain at.
As long as you are alive, it's
centimeters.
alive, it's growing.
Oh, okay.
So I would say before you go, remove that fibroid first, because remember in the beginning I've said that one of the causes of tubal tortuosity are tumors, ovarian tumors and fibroid. It might grow to an extent there, it grows toward the tube, whether in the isthmic area or interstitial area, and disturb the tubal motility there, ovum motility there, and predispose you to either infertility or ectopic pregnancy. My advice is remove that fibroid, because definitely today is not as big as it was before. It keeps on growing.
All right. Thank you so much.
Donald Amoko, how are you, my friend? Unmute.
I'm fine, my brother. How are you?
Fine.
Thanks for the excellent presentation. I just wanted you to clarify a few things. One, is there a role for chondrosynthesis in this modern world for the diagnosis of ectopic pregnancy, since we've got all the routes available? And similarly, so we really encourage people to do parasynthesis in trying to diagnose an ectopic. Thank you. Otherwise, thanks for the nice presentation.
If you look what the answer in this modern world, the role is not there. That's the exact answer. But I do this talk for South Africa. Is South Africa in a modern world one? The more precisely post-1994 South Africa. It's a third world where there are people in Ramalwa or behind the mountain there. If they take beta ECG there, it must go to Petersburg. It will take 3 days to come back. So there might be a place for somebody to do chondrosynthesis there. But as I said in chondrosynthesis, that it's not something that you can rely on. It can just increase your chances of saying this might be an ectopic pregnancy. I'm trying to look somewhere where I said chondrosynthesis should not be relied on. I think I said should not be relied on, but if it's positive, you find non-clotting blood, then diagnosis of ectopic pregnancy can be entertained. But in short, your answer is that in the modern world, the way there are so many modalities and sophisticated and specific and sensitive way of diagnosing ectopic pregnancy, there's no place for chondrosynthesis. I thought this is answered. But South Africa, we are in a situation where we are regressing so that we cannot leave the medieval methods of diagnosis.
Okay, but I think I agree with you, but I think when you look at it, you see, we're also moving forward. We should not say we are still in third world, etc. And I think virtually even GPs now have ultrasounds. I think what we need to do is probably, instead of encouraging them, we need to teach them how to do proper ultrasounds and to be able to detect things which are there. Because you said 3 things there which are very, very straightforward. You have a beta ECG, which is positive. You have a person who comes with a low abdominal pain. I'm sure most of these patients, most of the doctors we have can do an ultrasound and be able to detect whether there is a pregnancy inside the uterus or not. And I think that's what we should probably be moving towards. But thanks.
Thank you very
I enjoyed
much. Thank you, positive contribution. Afia, Matsimal, you want to contribute, my friend? Donald and Afia are gynecologists. They are my colleagues. They will add.
Thank you, Dr. Mahapa, for the excellent presentation. But I just wanted you to clarify, if my memory serves me well, your teacher, Sir Mohokong, used to say, for a ruptured ectopic, do not resuscitate the patient, because that fluid that you are giving to the patient will actually dilute the very little HB that is in the patient. And even if you had to give blood, that blood goes directly into the abdomen. So, and I'm saying this because there's a tendency for people in casualty to say ruptured ectopic and they start running fluids. And the danger will be sometimes they are doing, for example, a neuro case, which will take about 4 or 5 hours. By the time you go to theater, she's got a low HB. HB is 4, and she's already in DIC. I think we have to be very careful about the so-called resuscitation. Majority of patients with ectopic don't really come in hypovolemic shock, and those who we say they are actually in shock are the ones who became unstable because of our fluids. Thank you.
Yeah, I want to add to that. Laparoscopy or laparoscopy, management of ectopic, laparoscopy is part of resuscitation because you need to go and stop the bleeding before you give blood. Because if you give blood, you'll raise the HB and raise everything. Once you raise the blood pressure, what will happen to bleeding? Bleeding becomes worse. So you go to the theater first. That management, that surgery is also a resuscitative process. There's no anesthetist will say, I can't dope this patient because the HB is 6, because you want to go and arrest the bleeding and give blood. Professor Hawking was right that if you give blood, you just increase bleeding until you do what you call massive blood transfusion. Now you cause what you just mentioned, like DICs and other problems. He was right. I think it's true that if casualty diagnosis ectopic, don't try to give a lot of fluid there. Take it to theater, let the gynecologist stop the bleeding, then you can try to reconstitute hemoglobin. Isrom's iPhone. Isrom.
Hi, Dr. Mahapa. Hi,
How
Dr.
are you,
Mahapa.
sir?
It's Dr. Mujela.
Doctor?
It's Dr. Mujela.
Oh, Mujela, how are you? Oh, who got Mujela?
Good, how are you, sir?
It's fine.
Yes, good to hear from you. My question is about a lady that you counsel. You're trying to obtain an informed consent. You're counseling her for surgery. She's got an ovarian ectopic, and she says, or she declines your surgical option. Is there a role of methotrexate in this woman who still desires fertility sparing surgery or fertility sparing option for this patient?
In the first
Is
place,
there a role for methotrexate?
In the first place, Mujela, ovarian ectopic will never be intact. It will be bleeding. And the same treatment must be given. You inject the cytotoxic agent in an ectopic which is unruptured, less than 3.5 centimeters in diameter. Ovarian ectopic will be bleeding. It's dangerous. There's no place for medical management thereof. If a patient refuses treatment, you can involve as many people to come and counsel her, but there's nothing you can do. You cannot operate a person against her wish, a will. We try to counsel as much, but there's no role that you can convert to medical treatment. Just record down that she's refusing hospital treatment. If the outcome becomes bad, it's hard luck. But with good counseling, the way it's so painful, very few patients will refuse treatment. The problem is when you say she refuses your method of treatment, because you have told her what you are going to do. You said, I'm going to remove your tube and your ovary and your everything. That way you are scaring her because you want children. You say, I'm going to help you. And the method, the treatment usually in ectopic, you don't plan it prior to opening. When you open there, you see the situation. Then you decide, if situations like this, what can I do? Do I do conservative surgery? Do I do destructive surgery? You do it there alone. But if you say it before, you tell the patient what we are going to do, you might tell the patient the worst thing that can be done in here. In that way, she'll say, this man is going to make me infertile now. She might refuse. Why?
Yeah.
When you arrive there, you might find that you could do conservative surgery. Don't put definitive management before you open the patient.
Okay, thank you.
Yeah. Thank you, Dr. Mahapa. Unfortunately, I can't raise my hand.
Thank you,
Dr.
Okay, we'll get to Felix Masinge, Dr. Masinge after Pizzo. But Dr. Masinge is my age group, you know. He was born long before these computers. There's a way to raise a hand here. Somebody tell me, I used to know how to do it. Control. We'll go to where? Controls.
Reactions.
Reactions, yeah. Go there and we'll find reactions. We'll find reactions. Then you will say hands. Reactions. And I like, see, I've raised my hands. So,
There is
but I've recognized you, Dr. Masinge. I'll see you now. Pizzo, let's hear you. Then from there, Dr. Masinge.
Doc, I just realized how you were doing this.
I will unmute Pizzo. You have muted. You have just muted now.
Can you hear me?
Yes, it's Pizzo who?
Namani.
Okay, Pizzo Namani. Tell us. Thank you. Welcome, Pizzo.
Yes, Doc. I saw how you were doing salpingostomy with the laparoscopy. It looked a bit simple because your hemostasis was good. But for us who are doing laparotomy and trying to conserve the tube in the case where the contralateral tube is diseased, so achieving a hemostasis is a bit difficult, and we end up strangulating the tube and trying to conserve it. Eventually, we lose it. I just want to understand whether there's any better way to try to mitigate the bleeding, because we are struggling with that most of the time.
Yeah, and more often, as I say, there's trophoblastic cells there. Even now, sometimes when I'm trying with an aim of conserving the tube, I end up doing salpingectomy. Some patients will just you can't just do anything. But if the tube is unruptured and you manage to coagulate and minimize bleeding, you put vasopressin there or vasoconstrictor to minimize this, you can. Not all patients that you try to do conservative surgery, you will succeed. I also don't succeed there. And if there's bleeding, there's nothing you can do. You have got to really do salpingectomy. Converting to salpingectomy is not a sign of failure. It's just that the tube is not. You are not alone in that cycle. We are all swimming in the same pool. We end up doing salpingectomy while our aim we don't want to do in patients who still desires fertility. Dr.
Okay,
Masinge.
thanks.
Dr. Masinge is a senior anesthetist in Limpopo. Let's hear from you.
Yeah, thanks, Dr. Mahapa. In fact, I've got two questions, but I want to comment first on the gynecologist who said we should not resuscitate. No, that is not true. We need to do what we call hypotensive resuscitation in ectopics because we are worried about the cardiac output. We are not worried about the other physiological changes that occurs. You know, you're going to fight with anesthetist when you bring patient with ectopic without the full blood count. But I'm saying, as long as you can come with a ward HB as a baseline, because it takes 4 hours for blood to equilibrate, the patient will be paper white. Meanwhile, the HB is still normal. It takes about 4 hours to equilibrate. But my question is, which one are we considering when we look at the results or the investigation of a topic? Is it sensitivity or specificity? That is number one. I just want to find out which one do we talk about, because we get false positives, we get false negatives. Now, between sensitivity and specificity, which one are we considering? That's my first question. And my last question, which is my second question, is the one that we used to do in olden days. I don't know whether it has got room again in this new era, where after an ectopic, we were sounding the uterus and put either a bump curette or whatever to check whether there's some product of conceptus inside or not. Because I'm talking about this after I anesthetize for you 2 weeks ago on that heterotopic ectopic to say if one practice what we were taught in olden days, we would have caused an abortion on the uterus whilst leaving the one outside the uterus. I just want to find out whether is the practice that is cancelled or we can still go on with it.
Okay, let's start with that. Donald and Dr. Matsimela, I would like you to pitch in here because this question was raised by one of you. I think the sensitivity of the test is more better to look at than specificity, because specifically this test will tell you that this ectopic can be other thing. It might be sensitive enough to pick it up early. That's why I told you different types of tests that have got different sensitivities. So firstly, the other one, when you say, Dr. Masinga is an anesthetist, we are the surgeons, we always differ. When you give a patient who is shocked, Dr. Masinga said, don't resuscitate. You are giving it to Dr. Masinga to anesthetize a shocked patient, and he doesn't want a patient who is shocked, because if he dies in theater, it's his death, it's an anesthetic death. But the teaching is that, which was the teaching, which is still the teaching, is that laparotomy in ectopic is part of resuscitation. You must order blood and go quickly and clamp the bleeding and give the blood. He's right to say that you need to increase the volume, we have the blood pressure. That's why I say the position, it must be such that the cardiac output is not compromised. You put it in a head down position, blood flow towards the head, towards the heart, so they can have a reasonable cardiac output. Not to say we give a patient with 30 pulse who's overtly shocked. Very few patients will come very shocked. By the time she goes to shock, bleeding stops and it clots. So that is the problem that anesthetists and surgeons will always have. We can never solve it out. Everybody wants a stable patient. The doctor wants, the gynecologist wants a stable patient, so he wants to take him to theater now to stabilize it. Anesthetist does want to receive a patient who's near death, who's going to die in his hands. That's a big problem. The last question is, when you do an ectopic and you do a DNC, you sound it and do a curette and do a DNC, that is just a practice which is a ritual, because you have done a sauna, you have seen an empty uterus. Why do that? That used to be done as part of routine. That's why they'll confirm area stellar phenomenon, will confirm in ectopic. It confirms what? Because the pathology will tell you that I've seen the trophoblastic cells, both syncytial and cytotrophoblastic cells with the tubal mucosa. It's an ectopic. Pathologists can diagnose it either way, but it used to be just, I would say, a ritual that used to be done. When you do ectopic, you also do a retouch of the same. It's not necessary to do that, because if you do that, you said you might just abort an intrauterine ectopic. Theoretically, not so, because you would have done a sauna. On sauna, you have said, I've seen a gestational sac, a Beckel sign outside the uterus, and the uterus was empty. If you said the uterus was empty, definitely there was no heterotopic pregnancy. That's my input. Donald, do you have any input, or Afia?
No, I think you've said the right things. What is important, and that's the problem with the analysis. They don't look at our perspective. Our perspective is that if we have a pipe or a tap, as you have rightly said, so a tap which is bleeding, even if you try to put water on the other side, it just goes through until you close that tap. So for me, my approach has always been the anesthetist should really not refuse that patient, because whatever you do, the patient is going to continue bleeding and you will not be able to help the patient. So the best thing is get 1 or 2 units of blood available, go in, and once you start the operation, you can start running that blood. And that way you kill 2 birds with 1 stone. The anesthetist at least should be happy, and I will be happy as the surgeon. I think that's my only comment.
Okay, thank you.
Dr. Moko, I think you are correct. I think what Dr. Masinga is missing is that we are not saying take the patient who is shocked to theater. I'm saying if you look at patients who are actually got an ectopic, it is very, very, very rare to find a patient that's actually come with shock. 98, 99% of them, they come with a taxi. They don't even come with an ambulance. They are very, very stable. The problem is that this thing of people, doctors will start resuscitation in casualty. And that is what is actually results in a drop in the HP most of the time. Patients who usually become unstable, become unstable because of what we do in casualty. So the best management will be get the bloods, get all the blood products, rush to theater, and resuscitate on the table, not in casualty. Thank you.
Ladies and gentlemen, I like it. It brings a very controversial, very nice academic meeting. Unfortunately, our time is up. I'm happy that I've opened a little can of worms. We'll go and read more and change the management of conditions for the betterment of our people. I want to thank everybody for attending this session. The session will be closed now. Thanks for everybody for attending this session. Thank you.
I
would say. You never asked a question, eh? Dr. Peter Sugar Mona.
Yes, doctor, I was listening carefully. Thank you.
I see a lot of doctors, they don't ask, they keep quiet, and they're going to phone me and ask me later.
Our phone.
He's from Central.
Okay.
It was cleared. Good.
phone Dr. Mahapa.
Who's talking? Rogers.
Hey.
How are you?
Yeah.
Fine. I'm so enthused to be a gynecologist. Are you finishing?
Next year, I'm finishing.
You must finish and come and take my practice.
Yeah, I'm coming to take over, doc.
Sure.
Hey, I'm coming for that practice. Mabata, why are you taking this practice now? Hey, Mujela.
Thank you, ladies and gentlemen. I'm going to stop the video. Ladies and gentlemen. Thank you.
Thank